session, we are moving to the panel discussion. Today's panel discussion in our endoscopy session is going to be done by the moderator, Dr. Ishwaramurthy, our Honorary Secretary IAGS. He is going to get the topic endoscopy training for surgeons, a global perspective. To do that, he is going to invite the panelist, Professor Krishna Rao sir, the father of endoscopy in India, my mentor, and the backbone of IAGS. And we invite also Satyapriya D. Sarkar, the honorary treasurer IAGS, and we always fondly call him Mr. Colonoscopy, because wherever we do a training program, he is there with his colonoscopy the whole day, teaching hundreds of people. Close to 600 people have been trained under the IAGS, under our program of the endoscopic fellowship of IAGS. Thanks to him and people like Govindraj, all of us. And from UK, we have two personalities here. Dr. R. Ravindran is actually the HBB surgeon, working now as a consultant surgeon in the Royal Infirmary, Edinburgh. And also he has done a lot of ERCP. He is a passionate teacher in ERCP. And we also have Dr. Bala. He is from George Elias Hospital, working consultant there. He does a lot of colonoscopy work and done a lot of things, training the people. And also he is going to talk a lot about the training, how it happens in UK. Later we'll be joined by one other personality across the continent from USA, Dr. Aurora Pryor, the President SAGES. So we welcome you all for this very important panel discussion for the next 40 minutes. Endoscopic training for surgeons, a global perspective. Delegates, I'm going to take these panelists for your own benefit into 5 different categories. Endoscopic training, the evolution of endoscopy, assessment and credentials, and the importance of the teamwork. Because if you watch the last 5 decades, the technology, the training, and the teaching of endoscopy has been very fascinating. There is actually a revolution in the field of endoscopy, thanks to all these personalities, the way it's been taught, and the birth of ERCP, and birth of the colonoscopy and snare. We can go on and on listening and also reading the passionate story. To tell all these things, how the endoscopy training and technology evolved in the last 5 decades, we have our father of endoscopy, Professor B.K.R. sir, with us. I want him to look back 5 decades and also look forward for the next few years, how things are going to unfold from the surgeon's perspective. Over to you, sir.
Thank you, Ishwar. My interest in endoscopy came from an article in the magazine Science, which talked about a fiber optic instrument to look into the colon. I found that Professor Morrissey in Madison, Wisconsin, was having a 2-week course on training in endoscopy. And I was fortunate to get into that program for a period of 2 weeks. At that time, it was a fiber optic instrument, none of the advanced instruments that we have today. And with the fiber optic instrument, we had what is called as a teaching attachment, where one person can see along with the person who is handling the endoscope. Because of the poor lighting, when an important step has to be done, the professor will disconnect the teaching attachment. So we will be in the bit of a dark. But there were 20 Kodak carousels, if any of you remember. These carousels will have slides, hundreds of slides, and all these slides are teaching slides, which in the afternoon I used to sit, go through them, make notes, and try to understand and get clearance of any doubts from Professor Morrissey. During the morning, we will be doing all the procedures on the patients. As being in states, coming from outside and not registered in the American Society, Surgical Society, we are not allowed to handle the patient, but we can only observe and see the endoscopic picture with the teaching attachment. After that, the next progress in that was the camera that got attached to the fiber optic instrument, through which the image was transferred to a television screen, and by that we could demonstrate what we can see through the endoscope onto the television screen for a number of persons and explain to them what they are. The Fujinon, the chip endoscopy, was introduced in Chennai when we had a endoscopic training program at the Cancer Institute, and that has completely altered the visualization, transmission of image, and the teaching of the endoscopic procedure, and in particular the therapeutic endoscopic procedure, because the person who is going to assist you in the therapeutic procedure should also visualize what the operator is doing, and this was an excellent manner by which the assistant could see. Not only could the assistant, but a number of people in the room, in the auditorium, and if necessary, the same image could be transferred to any part of the world for comments and suggestions. Now, with the improvement in the endoscopes, which have provided you with magnification, selective screening by putting in the blue light and green light, and thereby determining abnormal areas in the mucosa, the knowledge and the imaging has been fantastic. And every year there has been so much of progress that what it was 5 decades ago and what it is today is unbelievably advanced. I'm sure that we will have an improvement in the capsule endoscopy so that we will be able to see many more things in a much better fashion and probably do therapeutic procedure along the procedures of the capsule.
Thank you, sir. But what was actually happening was an advancement in the field of laparoscopy that actually fascinated the surgeons more than the endoscopy, apparently. So a lot of surgeons moved towards laparoscopy, and I am sure Professor Krishnarao sir will agree. 20 years ago, more surgeons were doing endoscopy. Now there are less and less inclined to do. So that trend we are going to change, because the path less travel is a path we need to take, because that's where we are going to see a lot of fascinating developments going to happen. Because even our own endoscopy bodies like the Society of Gastroenterological Endoscopy of India, the recent paper, Endoscopy Training, Indian Perspective, they said the importance of classifying the training of the surgeons level 1, level 2 and level 3. The level 1, even for the MS postgraduates, they have to go the basic diagnostic upper GI endoscopy, flexible sigmoidoscopy, the least they should undergo. Now coming to the future of surgery and the future of endotherapy, because as a surgeon we know why surgeons to do endoscopy. We asked a simple question. I'm sure Ravi will tell why he thinks a surgeon ought to do an endoscopy, and what is the future of surgeon doing endotherapy instead of surgery.
I mean, I started interest in ERCP when I saw Professor Krishnarao doing his ERCP at Lady Wellington Hospital and Adyar Institute in 1992 when I was starting a postgraduate training in India. So we can go to the next slide. 1992 when I was starting a postgraduate training in India. So we can go to the next slide. And then one after that. Yeah. I mean, this slide gives a spectrum of various GI procedures where open and laparoscopic surgery used to be gold standard until recently. With progression of less invasive endoscopic techniques, these procedures are now becoming or have become standard treatment options. These techniques cover whole of GI tract, including treatment of vascular complications of cirrhosis like portal hypertension. Improvements in instrumental technology, enhanced digital resolution made these options a reality. Next one, please. With innovation in technology and thinking outside the box attitude, there have been further developments and improvements in already established endoscopy techniques, which widen the options of treatment. For example, achalasia, gastroesophageal reflux disease, and bariatric surgery are three different areas where refinement of existing techniques or development of new techniques have led to development of POEM, peroral esophageal myotomy, esophax, transoral incision-less fundoplication, and similarly endobarrier use. So, next one, please. A thinking surgeon combined with the technology development innovates for benefit of our patients to minimize discomfort to them. So, next one, please. Plato, a Greek philosopher, nearly 2,500 years ago, is credited with this quote in his famous 10-volume book, Republic. A need or problem encourages creative efforts to meet the need or solve the problem. We, clinicians who are in contact with patients, identify a problem that could be dealt with in a better way and use a technology to innovate. Next one, please. If you notice one thing, over the years, good outcome for our patients with safe treatment remained goal of surgeons. Treatment intention is the same, which we provided with big incisions with open surgery, modified with small incision using laparoscopic surgery, and now we go for endoscopic, natural orifice, or no incision surgery.
Agreeing that the surgeons, they have done already, our father, our grandfather, they're all here. They have done so much of innovation.
The first endoscopic banding by Stigman, a surgeon. First ERC by McQueen, a surgeon. First tenting by Shohendra, a migrated Indonesian to Germany, a surgeon. First by Ponsky, percutaneous endoscopic gastrostomy. And even the poem latest one, from Tokyo in Japan, is also a surgeon. So actually our seniors, our leaders have developed these things into the real therapeutic one. I'm very, very optimistic, very happy the way India teaching program of endoscopy for the surgeon.
Thank you, Satya. That is wonderfully said, and I am sure your passion for endoscopy is known to the Indian crowd. The quality of endoscopy done by a person depends upon the quality of training they undergo during their post-graduation or immediate early surgical career. Whether we are going to just teach them how to pass a scope down into the D2, or are we going to tell more about or stress more about the cognitive skill? These are the two things clearly should be understood. And also whether the training is going to be the bedside, like a person-intensive, you just be with a surgeon or a gastroenterologist for a few months, get to know how they are doing, or are you going to spend in a lab for a few hours with a simulation learn? And I just want, Bala, your view on how we go about in the training. You set the tone for our next few discussion on this aspect. Over to you, Bala.
Thank you, Ishwar, and greetings to everyone in the panel. Training in endoscopy is, as you may understand, is getting more and more difficult for surgeons because it's becoming a gastroenterologist minefield. But actually, endoscopy is no rocket science, and if we are able to do laparoscopic surgery, we're able to do complex surgical procedures, endoscopy should be an easy piece of cake, and it comes naturally to a surgeon when compared to a gastroenterologist. Cognitive skill is nothing but mental mathematics. So if you ask me now straight away, which button is for suction and which button is for air, I won't be able to think. Unless I think twice, I won't be able to say that. But if you give me the scope in my hand, it is cognitive It's just a cognitive skill and I know what I am doing. Same with both the wheels. Moving towards the endoscope, the smaller wheel is moving towards the left. But again, I had to read yesterday to think about it. But actually, if you give the scope to me, it comes automatically. So including handling the scope, consent, preparation, sedation, everything forms part of cognitive skill, which we develop over a period of time. And that's extremely important, as equally important as the technical skill, which you will pick up over a period of time.
I'm sure what they do in pilots, they put so much of importance to the simulation. I think slowly we are also understanding the importance of simulation, because we have understood personally in our training programs also. I'm sure our professors also will agree, because we use various types of model. I just want Professor Krishna Rao sir to tell about the static simulation module, like what we use for upper GI, teaching the upper GI, and also the St. Mark's colonoscopy, plastic tubing. They may look seemingly very simple model, but I'm sure they are useful. What's your view on the benefits and the limitations of this training, sir?
Basically, the person who has not handled a scope gets to know the functions of the scope and the movements of the tip and the various functionalities of the buttons, etc. Now, by doing this on a model, he is getting used to the idea of passing the scope, forwards, withdrawal, inflation, and deflection of the tip. And also, he can identify the landmarks in the model, knowledge of handling of the instrument in a model, and he does it a few times till he is confident of handling the instrument and identifying the structure, what he is seeing. Then he becomes a little more confident when he is passing it in a patient.
Ask Satyapriya regarding the computer-aided training, because we have this GI Mentor by the Symbionics, AcuTouch by Immersion Medical. There are so many different computer-aided virtual training programs. In laparoscopy, we have quite a few, but as far as the endoscopy is concerned, what's his personal experience and its benefit and limitations? Satya.
Thanks. I really feel that we have started our programs in Coimbatore, in Guwahati, but when we first went to Rajamundry Medical College in India, I really first got acquainted with the fantastic simulators which are made, and on which any diagnostic, any therapeutic thing you can do. You can take the biopsies, they can say, no, this turn is wrong. They can say you are overinflated. They can say you are perforated. So definitely, especially for colonoscopy.
I want to know the importance of the animal model, be it a live or the animal tissue model, which we call the easy animal or several porcine and bovine model.
ERCP procedures are associated with significant morbidity and up to 1% mortality, depending on which series or which paper you look at. As an alternative to clinical training, simulation practice have been used to enhance basic and some advanced skills of trainees. A number of simulators are available, including live anesthetized pig model. And what you're seeing in the video at the moment is an ex vivo porcine stomach model. The computer simulator different training models. The first one on the right side of you on the slide, published in 2003, did a prospective evaluation of 3 simulation methods: the anesthetized pig model, the ex vivo porcine stomach model, and the computer simulator using a GI Mentor by both experienced and inexperienced endoscopists. The ex vivo porcine model was rated as superior by trainers, whereas the trainees considered anesthetized pig model to be a better alternative for training. But both of them ranked lowest the mechanical model, probably because of the way the mechanical models are available those days. The second paper on the left, published in 2011, did head-to-head hands-on comparison of new ERCP mechanical simulator and porcine stomach model in terms of realism, usefulness, and applicability of the technique. Both were considered to supplement the training, but ERCP mechanical simulator was considered superior in all domains. Thank you.
That's great. Thank you very much, Ravi, for enumerating all this evidence-based literature on this animal. We learned a lot from you today. Coming to the live endoscopy session, which from the trainee, everybody wants a hands-on experience wherever when they come for this training. So tell us the benefits and limitations of this live training, especially in a training setup, Professor. I think he has trained so many thousands of people. He is the right person to tell the impact is going to have on the training aspect.
The people who come for training in endoscopy, after they've had some exposure to the models, would like to have a hands-on on live people. We know the difficulties. If you're in a private practice, they will not be able to handle it. And in a medical college, it becomes restrictive because the medical gastroenterologists have more say in the matter. The best way I have taught them is that if I have done the upper GI endoscopy or I have gone to the second part of the duodenum, I'll give the scope to them and I ask them to slowly withdraw the scope as they will inspect, manipulate, and rotate the scope, deflect the tip, use the inflation, use the suction, and probably do a biopsy. So in that way, they have a hands-on training during the withdrawal of the scope, which does not have any complications or any probability of a perforation.
What's happening as far as the training assessments are concerned from the various global governing bodies? Like we have JAG in UK and American Board of Surgery, SAGES in USA, European Board. IAGES is also having its own endoscopy board to govern the training standards as far as our courses are concerned. I'm sure similar things are existing elsewhere too. Coming to the UK, I just want to learn from Bala how the training is structured and how the surgeons there are assessed.
The endoscopy completely, both the service and the training in the UK are governed by JAG, which is the Joint Advisory Group on GI Endoscopy. We are lucky to have a surgeon as the president of the JAG this year. It's Mark Coleman from down south, the current president of JAG. So we are hoping that surgeons get more and more interest into this. They set standards for training, and every endoscopy has got a particular set standard which the trainee needs to achieve. Training in endoscopy for surgeons has always been a problem throughout the world, and especially in UK as well, and that's why I called it new approaches to an old problem. Next slide, please. What happens is that I am also currently the training program director of higher surgical training in the West Midlands. We do have a number of problems with GI trainees getting endoscopy training in the UK. And this is because of a number of reasons, such as we are not just endoscopists. Endoscopy is part of our work. Obviously, we are muscled out by gastroenterologists because they form the core group of JAG, and in every hospital, not in my hospital though, they are the endoscopy training leads, and they form a big part of training in endoscopy. So the gastroenterologists have a lot of time for this, whereas we do other things as well. So what we need to do is we need to get the surgeons to be integral part of endoscopy training, and that's what the focus is on. Downfall I feel for endoscopy training in the UK is because JAG accreditation is not necessary to get your completion of training. And because of this, every unit does not give us enough importance in endoscopy training. The SAC is quite reluctant to make this an part of CCT requirement, simply because at the moment I don't think it is possible to provide proper endoscopy training to everyone, but this needs to change in the future.
And I just want to set the tone and also tell our colleagues from UK that we do get training during our post-graduation, surgical post-graduations from the second and third year. But there is a lack of structured training, and in South India, for example, in our state, in Tamil Nadu, there is a quite decent amount of training is going on because every unit is equipped with the endoscopy and colonoscopy. But I can't speak for the whole country in India. It's so variable. And also, there are good training opportunities during MCH also. But when it comes to ERCP, there also people lack a proper supervised training. Professor Krishna Rao and also people like Satyapriya. During the time of Dr. Ramesh Agarwala as a president, we have formed a curriculum working group with a pilot training module. That is hardly 4 years ago. We have come a long way from there, setting the tone for a structured program with lecture modules, logbook, hands-on simulation, live sessions, and we have called 2 different things. One for the basic training in flexible endoscopy, that is a level 1, and the advanced training where we introduce them also for ERCP. But still, we haven't gone to the more theme-based training like dedicated interventional ERCP or ESD or US. That's our next job to do. For it, we need also equally more important is getting enough trainers also there.
We go to all the cases. We have 22 government medical colleges, and out of them, 7 of them are doing surgery department are doing independent endoscopies. Main problem is for the trainer. I'm really now teaching the trainers. This is one beautiful picture after the Association of Colorectal Surgery National Conference in Kolkata. We did a fantastic workshop, therapeutic and all. And after that, all the faculties and the delegates were just celebrating with a cake and with a firework on the cake. So that was a very memorable time for us. We did very nice therapeutic things and many were very happy there. It's from Assam to Erode. Actually, we have gone to every medical colleges. I am going there. 7 colleges I have made trainers. And I'm also trying to make good relation with the medical gastroenterologists. As in the Indian Society of Gastroenterology, I was in the executive body for 6 years. And also they recommended my name, and from there, the American College of Gastroenterology, I am the first one surgeon from India who got the honorary life membership.
Just a little note for a completion regarding the global. What's happening across the continent in America? Over to Dr. Aurora Pryor.
I would like to thank the organizers for the opportunity to speak today on endoscopy training in the US. I'm sorry I can't share this with you live and in person. I look forward to when we can actually see each other again in our meetings. So there's been some debate in the US and in North America in general about how endoscopy training should happen. And there's been a bit of a clash between surgeons and gastroenterologists about what training should entail. Initially, this started with numbers. And the numbers for surgical residency are 50 colonoscopy cases and 35 upper endoscopy before you can sit for board certification. For the GI fellowships, those numbers are much higher, with 275 colonoscopies and 130 upper endoscopies. It sounds like the gastroenterologist should have much more experience, but when you look at the practice of endoscopy across the US, most endoscopies are actually performed by general surgeons, with the gastroenterologists focusing their practices in urban areas. So clearly the training that we are getting in surgery residencies is important, but there has to be something more to establish competency. So what has been set up recently is something called the Fundamentals of Endoscopic Surgery. And this was something put together by SAGES in a validated and evidence-based manner to really do testing in both a written exam and a practical simulated exam for endoscopic proficiency. This became mandated by the American Board of Surgery, and now every graduate that is sitting for board certification has to have completed and successfully passed the Fundamentals of Endoscopic Surgery exam. In addition, the board, in cooperation with SAGES, put together something called the Fundamentals of Endoscopic Curriculum, which is really based on a really systematic approach to training the surgical trainees to ensure they're getting adequacy in surgical training. The graph on the right shows the number of trainees that we are training overall with the FES certification. And you can see now that we have nearly 5,000 trainees that have been certified through that program. And you can see in comparison our fundamentals of laparoscopic surgery program and our fundamental use of safe energy program. All of these, I think, are very validated ways to assure that you have competency. But there's still some controversy between GI medicine and GI surgery. So SAGES is now working on a multi-society, multi-specialty consensus to figure out a joint statement on what is really required to qualify for credentialing in endoscopic therapy. The societies listed on this page are participating. That group is starting to meet now, and hopefully we will have consensus outcomes based on all these societies with a GI medicine and GI surgery presidents that will be hopefully published in 2022. So there's a lot to be said for what's coming in the future, and training now is not currently consistent, but I do think that evidence-based training and proficiency-based curriculum makes sense. So I look forward to discussing this more with you in the future, and thank you again for the opportunity to speak today.
Thank you very much. But I want to hear from Bala what they do in UK.
JAG certification is the passport you get at the end of endoscopy training in the UK. Actually, I'll talk in the colonoscopy perspective because I do more colonoscopies and I'm a colonoscopic trainer. So it happens in two steps. One is provisional certification and the other one is full certification. What every trainee needs to do is they need to register first with JETS, which is the JAGS endoscopy training system, and log every procedure they do into this. It is minimum of 200 procedures to be done before you can be provisionally certified. So what is expected is by every 10th procedure, that is at least 20 DOPs need to be done throughout your training period of 200 procedures, an average of one every 10 procedures. We recommend you get one DOPS every list you go into colonoscopy. DOPS is direct observation of procedural skills. It is a holistic approach not only to technical skills, it evaluates your pre-procedure, your procedure, your way of doing the procedure, your post-procedure management of any pathology, and also evaluates the endoscopic non-training skills, such as your communication, leadership, team working, situational awareness, descriptive, but I think at the end of the day, you come out as a fully qualified and well-versed endoscopist who is safe to do the procedure. Thank you.
One additional thing I want to clarify, Bala, here itself. Certification, I fully agree. If they continue to do the procedure, fine. If they are, whether renewal of the certification is necessary 5 years down the line, whether they are because if you don't do enough number of cases every year, like ERCP in particular, they say at least 50 cases per year you have to do. Otherwise, you get hands are getting rusted, isn't it?
Yeah, that's true. That's true. Ishwar, we have again, JAG has got certain certification, procedural guidelines which every endoscopist has to follow.
Over to you, Ravi.
Yeah, thank you. Thank you, Ishwar. Bala has mentioned quite a lot about JAG. When high quality ERCP is reliant on high quality training. In the UK, JAG has given accreditation for flexible sigmoidoscopy, upper GI endoscopy, and colonoscopy since 2011. And ERCP is still, at the moment, there's no certificate process, but at the moment it's going to come out in this, later on. Who can be trained, who can train, and where they can train. So who, by whom, and where. So that's very, very important. We talk about the numbers later on. And as a trainee, they should have identified, they should have an appropriate commitment to learn ERCP. They should have post-ERCP training. They should have a job to go into to do ERCP subsequently, because the numbers are small. We don't want to dilute the experience of the trainees, and encouraged to attend complex HPB multidisciplinary meetings to learn about management of disease, the various treatment options, and management of complications of ERCP when things go wrong. And that kind of gives some feel how to act and how fast to act when complication happens. Various aspects of skills are assessed, like Bala mentioned, including cognitive, technical, and non-technical skills. I don't want to go through that again. And the trainers need to attend courses to learn how to give constructive, meaningful feedback without taking over the procedure at the first struggle of the trainee. And teaching technical skill is an art, like all of us know. We do that for open surgery, laparoscopic surgery. Similarly, endoscopy training is an art, and as a trainer, you need to make it happen rather than them passively learning. So that's the.
In IAGS, we conduct courses, we demonstrate all the procedures for the basic course and an advanced course also. We are going one step further and going to do a course only for ERCP for those who are interested and would like to improve their skills in doing ERCP. It's very important that when a person is progressing, that he is assessed about his capacity to do a more complicated procedure. Now, in IAGS, they have to pass the basic course before they can come to the advanced course. And if they have to come to the higher thing like ERCP, ESD, or POEM, they have to have completed the second step, the advanced course of endoscopy. Now, everywhere we have the theoretical, viva, and also the practical aspect of the candidate's handling of the instrument. He may not be able to ask him to do the procedure on a patient, but we can examine him on his capacity to manage a complication. So by this evaluation, we hope to say that the candidate is fit to proceed to do the advanced procedure. The certificate only shows that he has been trained to do the procedure, but we do not at any part of the time say that he is competent to do the procedure. There's a bit of a difference in these two. So the IAGS has, during this COVID time, come out with the modules of training, which has been accepted by the candidates because they can listen to the lectures, they can look into their videos, they can look into and have a discussion with the person who is doing the procedure at a time that is convenient to them. Previously, when we were having these courses, they had to leave their practice, come to another center, spend 3 or 4 days for this training. But now, with the virtual lectures and training, they can take the training at their own center, at their own convenience, and over a period of 30 days before they appear for the exam. So we have a stretched out period for the candidate to get the training in his own center at his convenience. So in that way, we are giving him the opportunity to see whether he can cope up with the advanced procedures.
Thank you, sir.
Thank you.
Satya, I think you have also been an examiner. We have an area where there is a mannequin kept, the technician is there. They also demonstrate the same procedure just to see how comfortable they are handling the whole thing. So we, to some extent, as Professor said, we have a way of assessing that this particular person at least satisfies the need for a minimum requirement to become a basic or advanced course trainee. That's what we do.
Then we accompany them and do this on simulator. Then we accompany them, take the practical training on the accessories and others. And really, if you are not satisfied, we gently ask them, you go for more training. Please be safe for the patient. Then only you can start this thing.
Do matter because there are lots of papers for constraints in time. I didn't put all those papers up. There are lots of papers published, particularly looking at the ERCP competency is directly proportional to the number of procedures you do.
the teamwork. Easily said than done. So let me just ask our professor, because he knows the importance of the teamwork, especially when he teaches this endotherapy. It is not just enough to have your tools and you go back and get yourself trained with the technology. You should have the right temperament and team. What's your views, Professor BKR sir?
Of what to expect and what to instrument to be given, and also in an emergency what they have to assist you properly. Many a time you will find that the person who is assisting you will be nodding their head if you're in the proper position and you're doing things properly, and you'll also see them shaking their head saying that you're not doing the proper thing. That is again a credit to you for having trained them to say what is being done is correct or not correct. So the teamwork, the radiologist who helps us in placement of the stents, extraction of the stones, and other procedures that require radiological assistance. Also, he may take over from you to do certain procedures like a PTBD when your ERCP is not successful.
Ravi, what's your feel about the team concept in your department?
Yes. In HPB surgery, as Professor Krishnarav said, is a team game. It's like your hand. You have 5 fingers in our hand. Each one have got different length and different shape, and they move differently. But you need to have all 5 fingers working for the hand to work efficiently. It's been shown that patient's management can be tailored for best outcome when there is a skill mix in the team. I've chosen a patient with the complication of necrotizing pancreatitis. If you could look at the picture on the left corner, a patient with peripancreatic abscess, and the one and the next to that is a very clear fluid with the pancreatic pseudocyst with good contact with the stomach. And the third picture with walled off necrosis with not much contact with any of the hollow viscous apart from the duodenum. And all these will require different type of management. And if you leave or give it to one specialist, they will come with one hammer and just hit with one nail. If you give it to multiple specialists, and the first one, ideally somebody who's septic, unwell, in intensive care unit with pancreatic abscess, initially you may want to drain percutaneously with the help of IR. And the second one you may want to do, which is quite nice, liquid and very, very kind of a cystic area, where endoscopic approach with using an Axios will be a fantastic approach for that. And sometimes you can, if this is a gallstone pancreatitis causing pseudocyst, you may want to a surgeon doing laparoscopic cholecystectomy and laparoscopic pseudocyst drainage at the same time in one go. And the third one, you may want to do a hybrid approach, possibly an endoscopic as well as a percutaneous approach, combination of endoscopy skills as well as the radiology intervention skills. So what we call as a minimally invasive retroperitoneal pancreatic necrosectomy, and a surgeon may want to do that by enlarging the tract and then using a nephroscope into the tract and taking out the necrotic material. So it's as a team concept that gives the best outcome for the patient. So we need to look at the pathology and patient condition and work in a team, and it's not who does the procedure and what is needed for that particular condition. Thank you.
Very nicely said, and I'm sure there's a lot to learn from it. I think it is a teamwork. We should not see ourselves, whether you're a surgeon or a medical gastroenterologist or radiologist, compete with each other. Patient at the center, whatever is right for the right occasion, do the right thing, and you get the right result. And it may be a collective combined effort. Piece is concerned. If you see the Apollo suturing device, there are a lot of devices are keep coming. As Professor Krishnarav said, last 5 decades, whatever he has seen, the last 5 years, we have seen an explosion of technological advancements are happening. So the future for surgeon is essentially on a flexible endoscopic working platform, which I am very, very confident about it. So every surgeon from henceforth ought to spend sufficient time with the art and science of flexible endoscopy. That's my way of looking at the things. So my one-liner for today at the end of this discussion is everybody should have the training of the scope. If you don't have a scope, there is no scope for you in the future. And what others want to say or convey to our audience today, by all means, Professor Krishna Rao sir, what do you want to tell the audience?
See, as open surgery has given way to laparoscopic surgery, therapeutic endoscopy will take over even from laparoscopic surgery, and majority of the surgical procedures done by the laparoscope can be done by therapeutic endoscopy. Hence, that becomes a very important tool in the surgeon's hand.
Thank you. Thank you.
Thank you.
Satyapriya.
I feel endosurgeons are magicians who vanishes your disease without leaving a scar. That's one line.
Thank you. Ravi.
Yeah. Know all options for the patient. Choose the right one with the patient's best interest in your heart.
Thank you. Bala.
I think success is doing ordinary things extraordinarily well. So endoscopy is not rocket science. You can learn it, but do it properly to keep the patient safe.
Very well done. From the IAGES office and EC, I thank Professor Krishna Rao sir, Satyapriya, and Dr. Ravindran and Bala from UK, and Aurora Praya from USA for having joined us for this very important aspect in the panel discussion, that is endoscopic training for the surgeons, a global perspective. Thank you all, and let us move on to the next thing. From here, we are moving on to the master video. Thank you very much.
Thank you.